Supplies Coalition.
This meeting is being recorded.
Thank you all so much for joining us today for this webinar, which is being hosted by the Coalition's Market Development Approaches Working Group, or MDA Working Group. This webinar, as you know, is titled Modeling the Case for Injectable Contraceptive Manufacturing in Sub-Saharan Africa. Just a couple of brief housekeeping notes. You will be muted unless you are speaking to the full group. And we will have a moderated question and answer period after the presentation. So feel free to enter your comments or questions in the chat box at any time during the webinar. And our presenter will address as time allows. So as I mentioned, the title of this webinar is Modeling the Case for Injectable Contraceptive Manufacturing in Sub-Saharan Africa. Our presenter today is Dr. Peter Stevens, who is the Director for Healthcare Stakeholders from IQVIA. Peter has been with IQVIA for more than 25 years, working with regulators, academics, and governments. 10 years ago, he led the work with MMV to establish ways to help regulators in Uganda and Zambia to record and analyze import data. Over the last 5 years, he's been joint technical lead for the construction of a health systems model to help the National Health Insurance Agency in Ghana to assess financial sustainability under different conditions. And a model to assess the clinical and financial impact of using substandard drugs for tuberculosis in Ukraine, and will soon start work to help generate and use geospatial, sales, and other types of data for TB case finding. Over the last 5 years, Peter has also worked with PSM, USAID, to understand the impact of different events on the public and private sector contraceptive markets in Latin America and in Sub-Saharan Africa. The work that will be discussed today started somewhat more recently, just over 2 years ago. So on that note, I'm pleased to hand things over to Peter Stevens.
Thank you very much, and thank you for inviting me to go through this. If we go to the next slide, I'll sort of explain roughly the way we'll go through this piece of work. We'll start off with just trying to explain some of the project background, where we've got to, a little bit of detail overview of the approach and the data sources that have been used, and then take a more detailed look at some of the assumptions that we've built into this modeling exercise, and then obviously show you the results of the modeling. But if we start with the project background, going to the next slide, I think, as some of you might remember from last year in 2021, we prepared, as it were, a preliminary business case for setting up a standalone manufacturing facility in Sub-Saharan Africa that would be dedicated to the production of modern contraceptives in FP 2020 countries plus South Africa, or FP 2020 countries in Sub-Saharan Africa plus South Africa. In one scenario, we looked at, if like, a facility that could make both injectables and contraceptives. And in another scenario, we just looked at a facility that could make injectables alone. And that preliminary business case suggested that the injectable alone facility was likely to be more feasible, if you like, more profitable than would be one that made or tried to make both. So in 2022, we sort of wanted to look at it in more detail at this particular injectable only business case. And then specifically, we wanted to understand better whether there would be continuing demand for injectables in FP 2020, Sub-Saharan Africa and South Africa. Wanting to understand, get slightly more robust estimates of marketing and distribution in those target markets. And we also were asked to think about and reflect in the model the increased costs of utility, construction and equipment costs that were being seen as a result of the pandemic and in terms of the war in Ukraine. In FY 2022, we also, as it were, added an extra scenario. In 2021, we were really talking about a standalone facility, but in 2022, we also modeled a shared facility. And that's because the WHO don't insist that hormonal products are made in a standalone facility. They allow, if you like, the hormonal products to be made in what's called a shared facility, as long as, if you like, various parts of it are separated off and on a dedicated part of the site. So in FY22 or in 2022, we're basically looking at only the injectable, but looking at it both in a standalone and in a shared facility. So if we go to the next slide, we'll just give us a very short overview of the approach. And again, as some of you might remember, what we actually tried to do and are trying to do is to build a virtual factory. So we're trying to generate real costs for how much it would cost to make or build a factory, how much it would construct it, what kind of works, engineering works you'd need to put in place, how much it would cost to buy the equipment and so on, how much it would cost to pay people who would operate the factory, how much it would cost to sort of rent the land, how much it would cost to pay for the electricity, the water and so on that you need, how much it would cost to actually make the product, the specific product costs, so including active pharmaceutical ingredient and packaging, and then other things like the cost of money, so finance, and depreciation on your capital costs. And we would take those costs and we compare it to revenues that we think we could make. And those revenues would come from both the public sector and the private sector. But just to note that given the kind of geographic confines of this model at the moment, which is FP 2020, Sub-Saharan African countries and South Africa, the bulk of the volume is basically paid for by donors. It's donor procurement. So 80 to 90% of the public sector is is basically donor products. Okay, so in the next few slides, we'll obviously be beginning to detail out the sort of assumptions that we're making. But first, we'll just go looking at some of the data sources that we use to derive these particular the assumptions that we made. And I guess it probably won't surprise that we used both quantitative and qualitative data. And the key quantitative data sources were things like the RHSC's LEAP report, which provided estimates of the current and future volumes of injectables likely to be required. USAID and UNFPA shipment data, which provided confirmation of the estimates that we saw in LEAP, but also gives us a breakdown of the types of injectable contraceptives and their packaging that USAID and UNFPA provide. Because South Africa is a key part of the geography, we also used and analysed, if you like, South Africa's published tender documents. We referred to DKT's published social marketing statistics and IQVIA's audits, if you like, on the private sectors in South Africa and Kenya. In terms of the quantitative side, we also went out in order to get some of these real prices that, if you like, would reflect. We actually went out to manufacturers and got pricing of the relevant equipment that would be needed to make the hormonal product. But also we went out to manufacturers of vials and cartons to get real prices in 2022. On the qualitative side, we basically interviewed various people in Ethiopia, Kenya, South Africa, and Uganda. We went out specifically to talk to local manufacturers, distributors, providers, and regulators and industry experts. And we basically really focused those interviews onto 4 or 5 things. So in particular, as I said earlier on, we wanted to understand distributor margins, but we also needed to understand expatriate and local salaries, the cost of money, so whether or not loans would be available, who from and at what rate, and basically looking also at the penetration of the different forms of MPA, medroxyprogesterone, so the subcutaneous version versus the IM version in both the public and private sectors. So those were the data sources, and we're now going to go through, as I was mentioned, some of the key assumptions so that you can understand better, I feel like, on what basis the results, if you like, or what they're based on. So those assumptions, if we just have a quick look at the next slide.
Pete, sorry to interrupt. We do have a couple questions if you'd like to take them now, or if we want to wait till the end.
Yeah.
So the first one, I believe you just addressed this in your comments, but referring to injectables, does this activity, include the subcutaneous, or are we only talking about IM for this particular work?
So yeah, we'll address this. I think on the very first point on the next slide, so it's a good one. But we looked at both, but the model, for reasons that I'll go into, basically is focused only on the IM.
Yep. And then on top of that, a question from Michael, are we looking at oily or non-oily hormonal contraceptive solution?
Well, I think that basically it's focused on the production of MPA, which I think is an oily hormonal contraceptive solution. But basically, we're looking at making a generic of MPA IM.
And then last question for now, could you please comment on the IQVIA private sector data quality in the target countries?
I can, and no doubt others may disagree, but the South Africa private sector data, I think, is very strong. It has almost, we take the data from almost all of the wholesalers and about 70 or 80% of all the pharmacies in South Africa. In terms of Kenya, there are gaps in the data. Basically, we based on what we sort of studies that have been done, we basically say that that there are about, we collect data from about 80% of the market in Kenya. We know that we cover the main distributors of MPA, but some of the sort of regional ones and some of the ones that go through social marketing or are used by social marketing are mixed, which is why when we looked at the Kenyan data, we took our data for this, as it were, the sort of commercial side of things, and then we used the DKT statistics for the social marketing side. And then we went for, in Kenya, we also I got an abstract from KEMSA. We don't need an abstract from MEDS because MEDS don't cover family planning commodities. Okay, hopefully that was an answer that people could understand at least, or they can disagree, or we can talk about them later. But if we go to the assumptions, as I say, they are go into 4 areas. So we're looking at what assumptions did we make about how much it would cost to build the factory, what assumptions did we make about how much it would cost to run the factory, what assumptions did we make about revenues, and what assumptions did we make about the cost of actually the money that we'll need to build the factory. So if we move to the next one, the next slide, we're starting off with factory build. And as we've kind of, I was just trying to say, we basically looked at a factory that would focus only on MPI-IM. So we knew that the factory was going to be, if you like, right from the beginning, was dedicated to the production of injectable contraceptives. And within this particular region, we obviously know that MPA dominates volume. We also knew, though, from, if you like, also from the interviews, but also from the USAID and UNFPA shipment data, that the subcutaneous version was making significant inroads. We did investigate the possibility of the factory making both IM and, as it were, a generic subcutaneous version. but initial investigations suggested that the making a competitor to the subcutaneous version at this point would not be economic. So we decided that we would focus down on the IM, and I'll come back to what does that mean for the volumes in a second. We set the size of the factory, so we have to and went out to someone who actually builds factories for pharmaceutical companies, and gave to them, as it were, a specification that would allow us to build a factory that could make about 20% of the total MPA volume. That gave us a factory of about 850 square meters, with that space almost evenly split between the sterile filling, the sterile packaging, and the warehouse areas. We then obviously needed to come up with construction estimates. Again, this person, Zaki, gave us estimates for the construction based on his experience of building about 10 pharmaceutical factories in the past. And we inflated those to allow for the reported increase in construction and costs that were being seen in sub-Saharan Africa through 2022. We had to pay for and buy manufacturing equipment. We basically went to, with the design as it were, and went to, if you like, manufacturers of those equipments and got those costs inflated, as it were, again to 2022 prices. But also when we looked at the equipment, we also have to allow for the fact that they have a theoretical maximum output, which is very rarely reached. And based on the equipment that we were buying and on advice from Zaki, this person who builds pharmaceutical factories, we basically sort of limited their, if you like, total production capacity, so that for example, the vial filling was 85% of the theoretical capacity. And that left us then we basically work out what kind of volume we could actually put through the factory that we had actually designed. As mentioned before, in 2021, we looked only at a standalone factory, and in 2022, we looked at a shared facility. A shared facility is a lot less expensive than if you like, a standalone new facility, for some obvious reasons, in the sense that you're not starting from scratch. You've got some land already, you've got some parts of the factory that you can share. So for example, like warehouse and secondary packaging, you've got some kind of additional elements that you can share, things like black utilities, shared purified water system, in other words, that don't actually you need to have a gain. And some of the labor costs that are incurred by a standalone facility aren't incurred by a shared facility. So certain things are already there. So for example, like a chief executive or a general manager, a plant manager, maybe the engineering manager, and so on. And that basically, if you like, obviously, so a shared facility is, for all of those reasons, is quite a lot less expensive to put in place than is a standalone facility. If we move on to the operating costs, so on the next slide. We can see they break down into, again, 4 different areas. Once we've built a factory, we obviously have to, if you like, staff it. We have to have people who run it. But one of the main reasons, as you know, for looking at this is to look at whether it's possible to make, if you like, hormonal products within sub-Saharan Africa. So we can say fairly confidently that there is no sort of live or extensive experience of hormonal manufacturing in sub-Saharan Africa. And as such, it was thought that we should really, if when we're looking at this factory, we should allow for the employment of expatriates with that experience in all key positions. So notably the general manager, the plant manager, the technical manager, the QA manager, the QC manager, the production manager, and the engineering manager would all be basically expatriate with experience. In the interviews that we had with the manufacturers, they also suggested that probably the production supervisor and operators should really also have that experience. And so at least until sort of the local staff could be trained, so maybe for the first few years. So as such, we've not only within the model allowed for the kind of key positions, or what are called the key positions, to be staffed by expatriates, we've also allowed for the production operators and supervisors to be paid as expatriates throughout the period of the model. In terms of how much we should pay them, or how much one would pay them, we basically went out to local manufacturers in Ethiopia and Kenya and asked them for, given these kinds of positions, given this kind of experience, what kind of salary would we pay a local staff and expatriate staff? And the model takes on the highest estimated salary for each position mentioned to us by the respondents in the interviews. Now, moving down towards the product itself, we derived the API and excipient prices from 2009 Indian import data, or Indian import and export data. MPA relative is much more expensive than the excipient costs, but the MPA price that we used was that we saw within the Indian export data comes from a WHO PQ'd supplier. In terms of the actual packaging, I think as mentioned right at the beginning, initially in 2021, we took estimates for the packaging from manufacturers, which was quite a difficult exercise. We had quite a broad range of estimates for packaging. So in 2022, we actually went out, if you like, with a specification and got actual prices for a particular specification from both, if you like, vial manufacturers and also carton suppliers. Just to note that the pharmaceutical glass manufacturer is globally known, as it were, and it counts as, if you like, various multinational pharmaceutical companies such as Pfizer, GSK, Sanofi, BMS as its customers, and supplies both Europe and USA, amongst other countries. So what I'm trying to say by that is that this is not, if you like, the price that we use for the vial is not, if you like, is a proper price from a well-known high quality manufacturer. As for the carton supplier, we asked them to supply prices on two different types of carton, one that would be a price for one vial and one that would be a price for a 20 vial carton. And the reason for that is that the bulk of the public sector volume is supplied as, if you like, in bulk packs in 20 or 24 24 carton vials, or 24 vial cartons. And it's a lot cheaper, or the carton is a lot cheaper per vial, as it were, for a 20 vial carton than it is for a single vial carton. So we wanted to reflect that properly within the model. So we got two prices, one for a single vial carton, one for a 20 vial carton. And we assumed that about 80% of the public sector volumes would be supplied in a packs of 20. And the remainder, i.e. 20% of the public and all of the private, would be supplied in a carton of one. When it comes to running the factory, we also sort of, need to think about how much it costs to rent the land, how much it costs to sort of pay for electricity and water. And those costs were taken from the published literature relating to the special economic zones, or so-called enterprise parks in Kenya and Ethiopia. And the most up-to-date of those was the 2021 prices published for the pharmaceutical park in Ethiopia, so the so-called Kalinto Industrial Park. In addition, just so you know, that certain things have also been taken into account. We also made allowances in the model for the costs of site insurance, IT systems, and repair and maintenance. And we also put into the model the cost of a bioequivalence study. We would obviously need one of those to get registration. And the price for that bioequivalence study was sourced directly from a company with an experience of more than 1,000 bioequivalence studies. And we gave them the protocol that is on the WHO PQ website for Incepta's formulation of MPIM. So we gave them, as it were, a protocol to make a price on, that is a real protocol, and one that was accepted, if you like, by the WHO PQ program as being an okay design. So that's operating costs. So we've built the factory, we've got some money that we think that would allow us to operate it. So how much money are we going to make? So if you move to the next slide, we can
Pete,
talk about.
before you move on to revenues, we have a couple questions from Kenny. In view of sustainable procurement, what estimate was given for local sourcing packaging, which may be available on QC standard? And then also same for energy sources, was there any sustainable sourcing options considered in the modeling?
The locals, originally we, as I say, got costs for the vial and for the cartons from the local manufacturers, and certainly the cartons could be sourced locally. It was just that, again, because we got such varying prices for the cartons, we actually went out to some pharmaceutical carton manufacturer that we knew was of certain QC standard. So that was the price that we used into the model. Potentially, if you like, those prices could be cheaper because they wouldn't be shipped for a start. You wouldn't need to ship them if they were sourced locally. We didn't look at any sustainable sourcing options at all, because basically we basically used the pricing, if you like, of that was available from the special economic zones or the enterprise parks, and we didn't do anything to do with off-site contractual quality assurance costs. We did add in, which I know is not what you're really talking about, but we did add in a cost for the WHO PQ process, which I suppose is some level of quality assurance, but the costs of quality assurance were taken as internal. So we basically, as it were, employed or virtually employed a set number of quality control and quality assurance personnel. Possibly, I think this is, well, in terms, I see the next question, positive effects on the community, employment, etc. Yes, but beyond the scope. The only thing I would say is that the cost for the local local staff that we would, as it were, virtually employ, at least within Ethiopia, the costs were inflated by 1/3 over and above what we were told by the manufacturers, because the association was keen to see higher salaries in manufacturing, to attract more people into manufacturing. So we took that as a given, that this was, if you like, something that might happen during the course of the model, and that we would therefore, should reflect that within the sort of the salary costs that we were taking. Okay, I think that's it so far on the questions, but we can always come back to any of them if I haven't answered them properly. So if we now move to revenues, which is on the next slide, I think. Yep. Sorry, no, I've got the chat open, so I couldn't see you'd moved it on. So when it comes to revenues, we have to make a decision about the volumes that we're going to be able to sell. And I talked earlier a little bit about the sort of the fast uptake that we're seeing with NPA-SC. So we saw that in the UNFPA and USAID shipments. We talked to sort of some of the people in the public sector, if you like, within Uganda and Kenya. And if you like, what we see in the shipment data and what we see in those interviews basically says that the NPA-SC is taking, or may well take, a large volume market share. Certainly is making rapid gains. And for that reason, the model assumes that basically the NPA-SC will take 50% of the FP20 SSA NPA volume. But as you probably know, the NPA-SC is not yet launched in South Africa, so there is nothing, if you like, within the assumptions of the model that reflect NPA-SC penetration of South Africa. We also obviously looked within the RHSC LEAP and in the South Africa tender data, a look at future growth, and we can see within, if you like, those documents, that there is growth within the NP market overall. I mean, the LEAP within FP 2020 countries, the LEAP report estimates around about a 3.6% compound annual growth rate, and the South Africa injectable volume has increased something like by about 8 to 9% compound annual growth between 2000 and 2022. So, but in the model, we were comforted, if you like, that there was likely to be growth in injectables total, so that, if you like, 50% of the total injectable market would be a larger volume in 10 years' time than it is now. But we, in order to, if you like, to be conservative, we just kept volumes as they are, otherwise they were estimated to be in around about 2019-20. We were also very keen, though, you know, whilst we're selling things, we still have to take into account certain other costs, and in particular marketing and distribution. And that was one of the focus of, if you like, of our qualitative interviews. And we basically found, as a result of what we could, that you know, and expressed it in the model as a percentage of the sale price, is that selling or trying to sell into the South African private sector was, and that is potentially not wholly surprising, was the most expensive, and that might well take up to about a third of the sale price, and then but it was less than that within the public sector, and in the private sector within the FP20 sub-Saharan African countries at about 15%. But if we take a look at the price, again, the price that we can sell things at, so we deserted the volume, we've made an allowance for how much it's costing us to sell, but we still have to set a sale price, and that sale price is different depending on the country or the market. So in South Africa, you have, if you like, the public sector and the private sector market. The public sector price was based on the 2021 tender that was awarded in 2021. And we took then the published National Department of Health allocation formula to work out what kind of price would give us a 30% market share or 20% market share, but we chose 30%, the price that would give us a 30% market share. The private sector is more difficult, but we used, again, the private sector data that we have in IQVIA for the private sector in South Africa, and looked to set a price that would allow for rapid generic penetration. And that price seemed to sort of hover somewhere around about 20% less than the current SEP price of, if you like, the originator, as it stood there within South Africa. So the price that we set in the South African private sector market was 20% less than the current SEP, the single exit price. In terms of FP 2020, the public sector price we based on the UNFPA catalogue price, and assumed that if we came in at that price, we might get something like 20% market share. Whereas the private sector price was taken as the IQVIA wholesaler price that we see in the Kenyan audit, but we assumed that we would get a lower market share in the private sector, despite obviously the fact that we'd be paying our distributors, as it were, as described before, and we would only get a 12% market share. Now I can see that some things came through on the chat, so maybe I should.
Yeah, Pete, there's a couple questions. Transport cost savings could be an opportunity for domestic manufacturing. Does this play out at all in the analysis?
No, I think not specifically. I think that would be. So we basically asked the distributors and so on how much it would cost, as it were, for them to market the product, and within the model there is an allowance, as it were, for transport from, as it were, port to export country. But we haven't compared those transport costs that we have in the model to what it currently costs to ship from wherever the product's coming from at the moment. In terms of respondents, most of the ones are from Kenya, Uganda, and South Africa. What about other sub-Saharan African countries? Well, we didn't interview anyone else in any other, well, Ethiopia would be the other one. But other than Ethiopia, Kenya, Uganda, and South Africa, we didn't interview any other countries. There was a reason for that. Ethiopia and Kenya, we spend a lot of time in, as it were, on the interviews because, in a sense, they're manufacturing hubs and there are incentives for manufacturers who set up in those two countries. And we chose Kenya and Uganda to look at the private sector interviews for terms of margins and so on, because they are, according to the RHSC LEAP report, the two largest private sector markets. And South Africa, obviously, we chose because it's a higher priced market that's still very close and open to a manufacturer in sub-Saharan Africa. Did we take into account the rapid increase in implants? No, not directly, but one hopes that the RHSC forecasts from 2019 to 2030 also would reflect that. So we use the absolute volumes that we see within the RHSC LEAP forecast, comparing, as I say, those to the UNFPA and USAID whatever, so to show that the base is the same. I think it has been taken into account, but via someone else's work rather than our own work. Was the price to use Ex Works or fully loaded costs, which is based on landing costs? Okay. So the way the model works is that it takes, as it were, the sale price in the country less the distributor margins that we're paying for people to both, if you like, to register the product and then to warehouse the product and then to sell the product. So I don't know if that exactly answers the question, but it's not an Ex Works. Eventually, it ends up, as it were, the profit that comes to the company is kind of like an Ex Works, because it takes a sale price less all the costs applied to it. Volume assumptions are flat over the model time frame. Yes, that's correct. I'm sure you didn't miss it. It's just I probably wasn't clear on it. And I can see Michelle has backed me up on the LEAP report, which is a relief. Okay, moving on to the next slide. This is the cost of money, so cost of finance. So it won't surprise you to know that if you're building a factory, it costs a lot of money. And we estimated so that the capital and labor costs to run this factory over 10 years. So basically it's sort of setting up, getting registration for 6, and then producing stuff for 4. For a standalone facility, excluding finance and depreciation, is estimated at about 92 million USD over 10 years. And that for a shared facility is 73 million USD. So we're looking for a sizable investment. And in reality, you won't get all of that from a development bank or a commercial bank. They will be looking for you or somebody else, if you like, to contribute some part to, if you like, the cost of the facility, upwards to maybe 50%. For the purposes of the model, though, we assume that the rate of return that we'd have to pay on that money, whether it would be for a, if you like, a commercial bank or a development bank, or if you like, for another investor, that they'd be looking for the same amount of return during that period of time. And we assumed that the loan term, so in other words, how long someone would lend the money to us for, would be 10 years. And we took that 10 years because that's what we were told commercial banks would be looking to lend money for, not necessarily longer. Though it's important to note that the development banks offer a lot longer than that. The Development Bank of Ethiopia basically offers up to 20 years. But if we take a 10-year loan, then it means that we have to pay off the loan, and all, as it were, accrued interest has got to be paid off within the 10 years. In terms of what those the banks, if you like, would actually charge to lend you the money, the kind of a common figure, for at least within Ethiopia and Kenya, would be 16% per annum for the commercial banks, and a development bank was going to charge us 9.5%. And we assumed that interest would accrue from the point at which we it took out the money from the bank. Capital costs, we staged, so we didn't take out all the money in year one. We took the money spread over year 1 and 2, but we assume that basically as soon as we take out any money from the bank, it accrues, and obviously unpaid capital, unpaid interest also accrues again. But we did assume that as soon as we were in production and were making some money, then we could start paying back that interest and start paying back some of the capital in order to reduce the total amount of interest that we would pay over that 10 years. So the cost of money is a major part of this money, but it's not the only sort of financial, if you like, part of the model. We also need to take into account depreciation and corporation tax once we start making any money. Depreciation is charged at 13% per annum. It's only charged on the capital costs of the equipment and construction and so on. But basically that's 13%. It's an industry norm for construction and for within pharmaceutical construction. And we took corporation tax that it would be charged at 30%. And we took 30% because that's the rate charged in Ethiopia. So hang on, before I move to the next slide, I will just check on the chat.
Pete, there's a question from Kenny on the policy and political front. Would a government legislation, mandate, or changes in the procurement model be a crucial driver for adoption?
Well, let me just say, we were attracted to Ethiopia because Ethiopia has made pharmaceuticals a priority sector. And not only that, it offers incentives or subsidies, if you like, for payments to expatriates. We didn't include those incentives to expatriates within the model because it was not necessarily the case, as it were, that it would be cited in Ethiopia. But the sort of encouraging government environment is obviously key, and will, you know, because of sort of risks of this is a sizable risk of investment. If the government's on your side, the other thing that's interesting about Ethiopia is that because it's a priority sector, it gets, pharmaceuticals are a priority sector, it gets like special treatment when it comes to the availability of foreign currency and in terms of expatriation of profits. So if an investor comes in from outside of Ethiopia, so not a domestic investor, they have some guarantees because it's a special area that they will be able to expatriate the profits that they make, or repatriate the profits that they make. So agreed that as well, it's one of the kind of key things that are difficult to quantify, and we'll maybe talk about those later. But it is that, you know, this political environment, the kind of stability of the country as to whether or not anyone would consider making this kind of investment in sub-Saharan Africa. But it is of interest clearly when governments have made statements to that effect. Okay, so then we come to, they're the 4 key areas, the 4 key assumptions. And then we move to the next slide, which is where we come to results. And just to confirm that in a sense that the business, if you like, or the economic feasibility of sub-Saharan manufacturing of this particular injectable contraceptive depended on 2 things. The first is that we had to make enough money in 10 years in order to pay off the loan. If we can't pay off the loan during the term of the loan, then obviously we've defaulted on the loan. And as a result of that, it would fail, as it were. That was our view, is that it wasn't economic to do so. And that what the other part of the, as it were, the test is what kind of level of profitability does the factory make once the loan is paid off. So we have 2 parts, if you like. Paying off the loan, it has to do it in 10 years. And then what's the level of profitability once it's paid off? So again, we had 2 scenarios. We basically have a model that looks for a standalone facility and a model that looks at a shared facility. The model for the standalone, which is the next slide, basically showed that we wouldn't be able to pay off either a commercial or even a development bank loan in a 10-year term. Now that 10-year term assumed that we would reach, as it were, production after 6 years, which was based, if you like, on literature saying one could build a factory in 3 years and get WHPQ in 3 years. It may be optimistic, but that's the way that the model works. Doesn't have to work like that, but even if you like being optimistic, if you might think, is that it cannot do it. It cannot pay off. It cannot make enough money on all the assumptions that you've heard so far. It cannot pay off the bank loan, commercial or development bank loan, within that 10-year period. It looks quite profitable afterwards, so it's making a return on investment after depreciation and after corporation tax of about 17%. But it doesn't matter. It hasn't passed the first test. It hasn't paid off the money, if you like, that it's taken out in the loan within the 10-year loan term. So if we move to the shared facility, things look a little bit more encouraging. You'll already have heard, in a sense, that a shared facility is a lot less expensive, if you like, to set up than would be a standalone facility. Theoretically, it can actually, according to the model, you could actually pay off even a commercial loan, so one that's given to you at a 16% per annum. But it's a pretty fragile business case. You're only just over the kind of the test. You're only making just about a 1% profit per year in the time of your production. So we figure that one's probably not really feasible. If we move to the development bank loan, we basically think things are a lot more encouraging. That they can basically make about 6%, and that 6% means that it can actually withstand quite a lot of change to the assumptions that we make. So it can pay off that 10-year loan, even if, as it were, the development bank loan interest rates increases from 2%, i.e. from 9.5% to 11.5%. It can pay off that loan if the price that you actually get paid in the donor world decreases by 15%. It can pay off the loan that instead of getting 30% of the South African public sector market, it only gets 20%. And it can pay off the loan